certi- certificate course in training in essentials of pediatric palliative care for pediatric palliative pediatric hemonc consultants as well as residents, postgraduates, and which is conducted by the Hyderabad chapter of palliative care as well as the Jerabai Wadia Children's Hospital. And as you know, it has been conducted by two of the stalwarts of pediatric palliative care in India, Veranik Dinath and Archana Iyengar. So thank you very much, both of you. And it's really very, very important. And I just heard that there are nearly 50 people who have registered for this course. So it just goes on to show how important this aspect is. And especially now that more and more pediatric patients are being treated, basically pediatric cancer patients as well as those with hematological conditions are being treated by pediatric oncologists. I think it's very, very important for them to understand how to integrate the palliative care in the treatment of these children. Because, as we all know, though we want to cure 100% of our patients, that's not so. And though pediatric malignant cancer is highly treatable, highly curable, there is a certain number of patients who would not be cured. And basically, very, very importantly, we have to make sure that these patients are taken care of with dignity. And very importantly, till recently, when we had the pediatric only tertiary centers treating these children with cancer, many of these patients, once they went home, when they had relapse or even simple pain or this thing, they were straight away shunned back to the tertiary cancer, tertiary uh, care places, because very few of the pediatricians or those taking care of this patient at the local level were trained enough to take care of this patient, and it was easy for them to be shunned back to the primary centers. But as we all know, it is very, very important that these patients are taken care of with at the best, with the best care at their local places, and they cannot come all the way to the tertiary centers for palliative care. Because as we all know, even the many of these tertiary centers are full of patients, and they hardly have any place to take care of palliative patients, so they lie on the road. They're not given the proper dignity, they are not given the proper care, and we have seen many of these patients suffer. And though we have taken care of these patients in the best possible way, the only thing that the parents remember in the end is that this the care that they did not get at the time when they really needed love and care. So I think now that we are training our both the consultants as well as PJs in the pediatric palliative care, I think more and more of us will take care of these patients at their doorsteps, at the place where they are most comfortable, that is in their home surroundings. And I think that is something which is we were waiting for a long to be taken care of. So again, thank you, Veronica and Archana, for taking this challenge up and doing this, because this requires a lot of commitment. As you can see, there are 9 sessions basically, and a lot of work is involved in taking this type of courses. So thank you again, both of you. And I know by the end of this training, more, and I know this is just the first course, and I hope this will continue, so that every person taking care of this pediatric patient is trained in pediatric palliative care and gets the best basically palliative care support, and at the end of the basically when the end of life. And we want to integrate, as we know, upfront only, but it's mostly required or most required when they are at the end of life. So I think thank you once again, and I hope this course is a great success. And there are many, many more of these courses which will be continue to be given by both of you in the future also. So all the best to the candidates, and all thank you again to the organizers. And on behalf of both the pediatric hemong chapter of IP as well as the Indian Childhood Cancer initiative, I thank you again, and all the best to the attendees. Thank you well. Bye.
Thank you very much for your encouraging words. And definitely having such a small number to start with, because we wanted to limit it to 40, it was very hard. I mean, hard because
No, 50 is a great number.
no, so many
Yeah,
more would like to do it,
yeah,
I'm sure.
yeah,
So we will have more
yeah.
certificate course essentials, and then we'll have advanced course for those of you who want to go ahead and learn more.
Yeah. And I and Manas had gone through the course. It's a very well curated course. So I think it is really, it's going to be a great learning for all of us.
Thank you, sir. And yes, many faculty will be, national faculty will be involved. So, so then we'll move on. I think that a few of you need to maybe you rename yourselves. And I want to make sure that all of you have seen also the Google form that will help us to get to know you better, to know where you work, how much familiarized you are with the concepts of palliative care, how comfortable you are in your practice. Um, at the moment. And then we definitely, this is just want to improve over the 9 weeks that are there ahead. So I want to introduce Dr. Archana, who is co-chair along with me of the palliative care uh, task force of the ICCI, of the Indian Childhood Cancer Initiative. We are also part of the INFOG, the chapter of palliative care chapter. And yes, we are very happy to kick off, to start with today's presentation, today's class, which is Introduction to Pediatric Palliative Care. So we are going to go it will be very simple. What are we talking about? Why do we need pediatric palliative care? When to approach palliative care? For which children? Who will be the beneficiaries? Where can it be provided? And how? So what is pediatric palliative care? According to the WHO definition, it is an approach to prevent and relieve health-related suffering of adults, children, and their families facing problems associated with life-threatening illness. It is based on a comprehensive and person-centered approach addressing physical, psychological, social, and spiritual suffering. And these ideas are going to come again and again throughout this course. We are not only interested in relieving physical pain. And it is both preventing and alleviating all these four aspects of suffering. And there is an association in the UK, Together for Short Lives, which defines pediatric palliative care specifically as the active and total approach to care for children with life-limiting or life-threatening conditions that embraces physical, emotional, social, and spiritual support from the point of diagnosis throughout a child's life, their death, and beyond for the wider family. So we are talking about a child and family-centered care for any child facing either a life-threatening condition, such as cancer, such as aplastic anemia, or a life-limiting conditions, such as thalassemia or sickle cell anemia, and many others, which will be the lifelong of the child. I love this, which is more than a definition, which is written by this poet and philosopher, Mati, who died at the age of 14 of rare myopathy. And he said that palliative care no longer means helping children die well. It means helping children and their families to live well. And then, when the time is certain, to help them die gently. So what we are looking at is the quality of life. We are not talking just about helping children die, but quality of life of children, the children you look after from the time of diagnosis till cure or till maybe chronic illness or till death, if that is to happen. So the palliative care model looks at three levels of palliative care. The primary palliative care, which is for all healthcare providers in the periphery, in the community. The secondary level, which is generalized palliative care, which all professionals with basic palliative care training can provide. And that is where that is the level that you are going to acquire through this course. And the tertiary level, which is specialist palliative care, which requires an interdisciplinary team of experts in palliative care. And why this interdisciplinary team is very important. The next slide will show us how we, Archana, yes, thank you. In order to approach all the needs of the child and the family, we need not only physicians, but palliative care trained nurses, psychologists, physiotherapists and occupational therapists, dietitians, social workers, and child life specialists to have the whole gamut of palliative care. And you will hear from various people during the course of during this course. And yes, please, if you have any questions, please post them in the chat. So the concept of total pain, you can click another time, came from Dame Cecily Saunders. Another click, Archana. Thank you, to show her photo. Yes, which is total pain is not only physical, but also emotional, social, and spiritual. And that is what we will be speaking about when we talk about palliative care, how to relieve that suffering, that total pain or total suffering. And Archana will take over.
Yeah. Thank you, Veronique, and welcome to all the pediatric hemato-oncologists today. So why is pediatric palliative care necessary? Because some places they might have adult palliative care, but pediatric palliative care is very, very unique. Why is it unique? Let us see. So it is unique in terms of disease burden. So as all of you know, the diseases in children with respect to malignancy is far different from adults. We have more of blood cancers, we have abdominal masses, we have bone tumors and brain tumors. The symptom burden again is very, very different from adults. It can be as common as pain, mucositis or dyspnea. Or in children, depending on their age, you can have smaller children having distress just that they are away from home or away from a grandparent or are away from one parent. Bigger children, again, missing school, that might be a source of distress. And still, adolescents might have issues about body imaging. So the symptoms vary according to the age of the children and also the disease, which we need to address too. And coming to assessment of distress again in children, it all depends on the age of the child, the intellectual ability of the child, the severity of the sickness of the child. So we have different modes of assessment for different types of children, if they are neurologically impaired, if they are very sick, if they are depending on their age. About that, we'll be having another session in detail, so I won't go into that now. I always remember my teachers used to say pediatrics is not half adult study. So similarly, the medications what we use in pediatric palliative care is just not half what we use in adult palliative care. It's all very specific and again weight based, as all of you know. We have something very, very exclusive and specific to children regarding procedural pain, which is a very preventive pain, preventive method where we can care for the children and we can prevent abandonment of treatment or the fear and anxiety which builds up over time in the journey of their illness, both for the child, the parent, and also the nursing staff, which we address to throughout the journey of the illness. Coming to play, all of you know that a child and play always goes hand in hand. A child who doesn't eat, we are not very worried, but a child who doesn't play, we always worry. So, play is not only for making the child feel comfortable even when the child is in the hospital, play is also done to divert the child during procedure, and also play has a very important role in a child who is in end of life or who is very sick. With play therapy we can explore the emotions of the child and help the child in end of life. So we have play in different phases of the child's disease. Grief is again very different from adult palliative adult patients, because the grief is so intense in a in pediatric setting where the family is involved and the emotions are very intense, and most of the time what we see, it's complicated grief also we'll be talking to you in detail in a few classes ahead. So we see complicated grief in pediatric setup, both among the parents and in the sibling. Again, it's unique because of the communication which happens with the parents is very different from the communication that happens in an adult setting. Many a times we have even uncles, aunts, grandparents, cousins coming, and maybe it might require multiple times communication, and we'll be exposed to different emotions at different sessions of counseling. Sometimes we also get teachers and social workers and religious leaders who come and care for the child. Many a times the teachers also come and say this child was so good and suddenly he's not coming to school and we wanted to know why. So this all happens only in pediatric palliative care. End of life care is again very different from adult. The child is so precious and center of the world for the whole family. So end of life care is very different, very distressing to the family, again to the staff. And there's an exclusive thing which we also do in pediatric palliative care, which is memory making. It's not compulsory, but the option is always given to the parents. It can range from either just naming a small baby, the cradling ceremony, or all of the family having a meal together, or taking some pictures, or having a festival or a birthday celebrated in advance. And understanding of death again is depending on the child's age and child's intellectual ability. So what the child perceives as his or her death depends on her age, and then depending on that, we explore into that and help the child understand. And coming to bereavement, which is very exclusive to pediatric palliative care, bereavement is done to those bereaved families, usually 2 weeks after the death of the child, and then 1 month, and then after 2 months to support the grieved family. So why pediatric palliative care? One, I told you all that it is very unique from adult palliative care. So it is a must that pediatric palliative care should be there for every child who needs it. And coming to the statistics, almost 4 lakh children are in need of pediatric palliative care in India, which comes to around 34 children per 10,000 population. I think Veronique will continue. Vero, over to you.
There is a question in the
Thank
chat.
you very much. Yes, so Joey is asking, what is the difference between psycho-oncologist and palliative care specialist? So this is a very interesting question. So you have a psycho-oncologist in your hospital, which is wonderful. It's very helpful for all the children who are diagnosed with cancer and treated with cancer, to have a psychologist who is specialized in oncology, especially in pediatric oncology. But not all children, like palliative care services, you are going to see the scope is a bit different. So I think this question is going to be answered by Archana, saying who are the children that you see in your practice that will need pediatric oncology, simple pediatric oncology care, and those who will need additional palliative care specialists. So those psychologists that we have on the team are highly trained for managing difficult conversations, and also to tackle issues which require referral to palliative care. So this is going to come a little bit later. And if the family insists not to inform the patient about the non-curative option, despite insisting for the need for him or her to know how to proceed. So yes, this is something we are going to tackle more specifically in the
Communication class.
communication. We'll have 2 sessions on communication because it's so important. Both communication with the parents and family and communication with children. Children, that is patients and also siblings, care for the siblings. So it is not easy. It's not, we cannot answer this question in just one session. But we definitely never talk to the child unless the parents agree for that. But we explain to the parents the benefit of telling the child. So when do we need to provide palliative care in PHO? So I will be partly answering your question, actually, Juhi. So let's take the case of this 12-year-old girl who was diagnosed as a standard risk PB-ALL, and for whom the pediatric oncology team called the palliative team from the moment of diagnosis to break the bad news. Because for teenagers, we have difficulties, and specifically this question arose of the parents not wanting to tell a child. And so we could have an open conversation with the teenager, after explaining the benefit to her parents and after obtaining their consent. And once the child is referred to palliative care, throughout the treatment, palliative care is integrated when the child has a need for pain management because of mucositis. She developed severe vincristine-induced neuropathy, for which, again, for the pain management and for all the rehabilitation that followed that, and the emotional support that the girl needed, that the parents needed, alongside. So it can be, we have the psycho-oncologist, we have the psychologist of the oncology department, along with some additional support, you could say, from the palliative care. And then helping her to catch up with studies. Our child life specialists are involved not only in play therapy, not only the plant therapies, music therapies, but also the children's book and toy librarian, who is focusing also on studies, for example. Then she developed septic shock during reinduction and was shifted to the ICU, was on inotropic support, ventilatory support, intubated. And that specific night, another teenage girl with leukemia died in the opposite bed. And the parents said, "This is too much. We want to give up. Please remove this ventilator, give her our daughter, we'll take her home." So it took a lot of effort from the palliative care and the oncology team, because we were all involved in her care from the very beginning, to encourage her to hold on. So giving them reasons to hope. And with intense emotional support of the parents, they, of course, they managed to hold on. She improved. She recovered from septic shock. She completing her maintenance therapy, went back to school, and is now in 10th standard. So, no, not in 10th. She must be in 9th. Anyhow, I don't remember. So that's, you can see the benefit of early integration of palliative care in pediatric oncology, not just waiting for the time the child will relapse. So at the time of diagnosis, which children need to be referred? Those with high-risk disease, because there will be a need for shared decision making to help them to help them understand and all the options, and make the decision for which option to follow, with high symptom burden. So a child may need very intense need of use of opioids at the time of diagnosis, and once maybe for an ALL, once the prednisone steroid prephase works, then we can taper the opioid, the morphine, very fast. because the pain will reduce, or for a solid tumor, maybe for longer time. High symptom burden at diagnosis, or children or maybe teenagers for whom it would be more and more difficult to speak about the diagnosis, breaking the bad news. Then, along with curative treatment, again, when high symptom burden is there, when we have significant treatment-related toxicities, such as the example of this girl, mucositis is something we see very commonly, such as significant toxicities going in and out of ICU, and complex psychosocial issues for the child and the family. Then, of course, that you are more familiar with that, progressive disease, refractory disease, a child who relapses, again, when there is a decision-making process, whether we should go for salvage therapy with a prognosis that is worse than it was at the time of initial diagnosis. And at the end of life, when disease is progressing. So in short, throughout the illness trajectory, you may want to refer to tertiary palliative care for help. And Archana.
Yes. So, who are the children we are looking who come under our palliative care, pediatric palliative care? So, the first group is children with life-threatening, but when curative treatment is available, that is all the children who you all take care of. We have another group where the child is diagnosed a few years after life, like cystic fibrosis, maybe which is diagnosed around 3 years or 5 years or 6 years, or some conditions of neuroregression. It might be SSP or adrenoleukodystrophy, which is diagnosed after a few years of life, but we know that child will have a limited life. The third group is progressive condition. That is, on day one, we know that this child requires palliative care. Examples like inborn errors of metabolism, Sanfilippo, SMA. These conditions, we know that the child requires palliative care from day one. And the fourth category is when there is severe disability during perinatal period, when the child is exposed to severe hypoxia, and the evolving hypoxic and ischemic encephalopathy leads to cerebral palsy. That is a fourth category. So because today it's all about pediatric hemato-oncology, we will focus on the first category and see the trajectory of children with cancer. So we all hope and always hope for the curative phase of the child. So once the diagnosis is done, the treatment is taken, the child can go into remission, which we all always look forward to. But unfortunately, sometimes the remission phase will end and the child might relapse, and then again when the treatment is given, it might fail and end in death. So this is a trajectory of a child who's having a life-threatening condition or a condition wherein treatment is available but it fails. So this is the first category wherein pediatric palliative care is required. Over to you, Veronique.
So where can we deliver palliative care? Pediatric palliative care can be delivered anywhere. In the hospital, I'll take the example of this 13-year-old boy who had osteosarcoma of femur. It was a huge mass that was fungating, and he had severe pain managed with oral morphine. So neoadjuvant chemotherapy was done, followed by limb salvage surgery, limb salvage surgery was not possible, so amputation was done. And emotional support was provided prior to amputation and afterwards. He completed his chemotherapy, and 2 years later, he had a mass on the right arm with pulmonary mets, and biopsy confirmed osteosarcoma relapse. So unfortunately, in his native state, an amputation of the upper limb was done when there was not much benefit of that. And then we were able, he came to the hospital, he came to Bombay, and we were able to guide him towards the nearest palliative care services in his state for end-of-life care at home. With appropriate management of breathlessness, appropriate management of pain. So delivery of palliative care starts in the hospital with early integration inpatient and OPD-based services. And most of those services are provided in tertiary care hospitals. So I don't know where all of you work. Usually when we see children with cancer, you may be in a regional cancer center, you may be in a tertiary care hospital. Most of them have a palliative care department for adults, and usually not very much adapted to children. So it's part of our responsibility also to train adult palliative care to cater to children. But also when you work outside a cancer center or in possibly NABH accredited hospital, all of them have for pain services and or end of life care policy, which is part of the requirements for accreditation. And if it is not there, you have to push for that to be available in your hospital with availability of narcotics, especially oral morphine. And the transition to the best supportive care, that is once we are not looking at a curative option, that transition is challenging. And it's very difficult for an oncologist to do it alone. Just go to people who can help you to do that. So delivery continues in the homes, but it's not always the best place. As we did for the previous trial, we had comfortable end-of-life care at home. But this 15-year-old with relapsed ALL went for salvage chemotherapy and had a second relapse, after which he was put on palliative intent with oral metronomic chemotherapy. So symptom management was done at home. He had bony pain, he had pleural effusion and dyspnea. So we managed him with oxygen concentrator, with morphine, and he was on regular home care with visits from three members of the team, doctor, nurse, and counselor. At some point, they panicked and they rushed to the hospital because the child had dyspnea, terminal dyspnea, and that's all right. Even though they have made the decision to be at home, he was admitted for end-of-life care and died in a separate room, a private room. We do not have much of private room in my public hospital. If we had a hospice, which is available in Hyderabad, Archana, and you will hear about hospice care, that would be probably the ideal, which is intermediary between home and hospital. So the place of care depends on the choices of the patient and the family. And those choices may suddenly change, and we adjust to those changes. It is not our role to say, you will be better at home, or you will be more comfortable in the hospital. We give them all the options. So their wishes are definitely the most important thing we look after. But then we need to provide optimal palliative care in any of those settings: home, hospital, and hospice. So home may not be the best, even though it's often preferred by the families, because there is patchy access to palliative care outside large cities. They have often to travel back to their native place. So we need to ensure morphine access. They have to go with enough morphine for the number of days or weeks we think they are going to live. And in the case of relapsed solid tumors, it's going to be months in many a time. So we need to provide the closest access from their village, giving the contact of other palliative care services, and provide anticipatory symptom management with liaison with a local physician, which may be an MBBS doctor, which may be a pediatrician. That would be the best. Of course, if we have access to more to pediatric oncologist or palliative care physician, that's excellent. With 24/7 telephonic contact with the palliative care team. So, and then in the hospital, End-of-life care will provide comfort care with decisions of do not escalate and do not attempt resuscitation that in most of the hospital settings need to be clearly documented. So we will talk about end-of-life care there will be a section about that. And hospice care, we have very few in India that are specifically for children, where we have only children or we have a separate wing or a separate floor for children, which are Can Kids in Delhi, Mandala Hospice in Hyderabad, Sukun Nilaya in Mumbai is just starting to have children, Manipal Hospice and Respite Care Center in close to 4 kilometers out of Manipal in Udupi. But there are many other hospices that accept children. So there are adult hospices which may once in a while have children. So you can look at this list. If you need anytime, any contact, we are available to be able to direct you towards the closest palliative care services. So, and it is growing, thank God. No, so we have in the north, in the west of India, south, in the east, northeast, and in the north. So tell us how can it benefit?
Yeah, thank you, Veronique. So, as she said, every child should receive pediatric palliative care wherever the child and family wants. So, wherever the child needs, how do we deliver palliative care? So, we have few core palliative care principles. Practice one being we need to build a very good therapeutic relation with the child and family, which involves sitting at the same level as a child and family. We usually don't prefer to talk to the family in the corridor or bedside, where one of us might be standing and the other is sitting. Sometimes to talk to a child, we might even have to kneel down. If the child is playing, maybe we need to start the conversation with the play. Eye contact is very important. Most of us, when we need to deliver bad news, none of us really like to give bad news to anybody. So many of us might not be comfortable in eye contact, but this is very important. And most of us again tend to talk and tell the information so fast what we all know, and it becomes very difficult for the family on the other end who is so stressed out to perceive everything. So we need to talk very slowly. And in palliative care, it's always listening, listening, and listening. We need to listen to understand exactly what they are going through. Practice 2 is understand the illness from the child and family's perspective. It is very important for us to recognize the distress in the family. It is important for us to recognize that the parents have done their best. We need to recognize that the parents were good, because so many times the parents feel guilty that they might not have come at the right time, they might not have come to the right place, or there was some misdiagnosis in the beginning. So there's a lot of distress, lot of guilt in the parents, which we need to recognize and then support them. We need to reassure them that the palliative care team is always going to parallelly work with the primary oncology team, and always decisions of the palliative care team will be dependent on what the primary oncology team takes, so that they will know both the teams are taking care of the child with the child-centric and family-centric care. It is important to give clear and honest information to the parents and the child in case the child wants to know, to avoid confusion. We usually describe about our services if we have home care, if we have hospice, so that the child and the family know that there will be a continuum of care even after discharge. And throughout the conversation, we need to be very sensitive in our talk, because we are dealing with the parents who are under high stress and emotions. Practice 3, giving patients and family the information they need. So usually we use the spikes model, wherein again in the communication class we'll be having a detailed discussion on this, wherein S is the setting up of the meeting, P is perception of the parents or the family, I is information, K is knowledge, E is emotions which can happen at any point of time, not in this order of spikes. And S is summarizing. So this model, we'll be doing a role play and again having a detailed discussion in the communication class. We also have something called the SICG, the Serious Illness Conversation Guide, which we use when we know that the child is deteriorating, the child's prognosis is poor, and usually when we know that the child has maybe weeks to days to weeks. So here we use three words which help us to communicate in a particular structured way to the family, where we say we wish that your child lived long, but we are worried that the disease is progressing fast. So we wonder how comfortable we can keep the child till she lives. So we usually use this wish, wonder, and worry, which helps us to explain to the family as well as support them during the communication. Many of us initially we used to think that by telling the patient and the family the actual diagnosis may be there, we are taking away the hope. But studies done has shown that before information, the hope that was there was 44.2%, and after information, there was not much decrease in the hope that the family had. Probably when you discuss well about the diagnosis and the plan, they have more of clarity and probably they are able to take care of the child better. So we always say we need to provide goal-directed care. So every time we need to insist that our goal of care will be curative as long as possible. In case a child is not doing good or the disease progresses, then we need to have a goal of care where we are going to control the symptoms as much as possible and give a good quality of life, a pain-free life for the child. And in case, unfortunately, the child progresses even more, then we need to give the child a very comfortable end-of-life care. And in palliative care, we hope always that the child has a good death. In case the child doesn't get cured, the child should be symptom-free all through. And in case a child progresses to a terminal event, he should have a very comfortable end of life. So there should be hope initially for a cure, then the hope should be for a good symptom control and pain-free period, and then the hope should be a comfortable end of life. So we need to know how to respond, to recognize and respond when a child or family is in distress. This distress can be physical, as already said, it can be dyspnea, it can be delirium, it can be pain, it can be emotional, social, or spiritual. Again, all these can be there in the child, it can be there in the sibling or in the parents. So we need to assess and treat these symptoms and then explore emotions and experiences what they are facing. And most of the time we may not really have answers to the questions asked by either the parents or the children, so we can just listen to them. And many a times, though we don't fix the problem, the listening is very therapeutic and the child or the family is benefited. Just to complete the palliative care scenario, so we have a 12-year-old girl with the swelling of the right scapula diagnosed as Ewing sarcoma. So she had pain in the area of the swelling, which was initially pulling type. On a finger span scale, she said lot of pain. This is one of the scales that we use beside NRS or the Facie scale. And she also had radiating pain to the head on the right side, which was throbbing, and she had disturbed sleep. She wasn't able to turn and she was hence forced to sleep on left lateral only. Because of sleeping on that same side over the next 4 months, she developed a bed sore. The wound progressed and had foul smelling discharge and there was intermittent bleeding. The child also developed respiratory distress. It was because of lung metastasis. And the child was drowsy most of the day and awake only for a few hours in the day. So the palliative care issues here in this child, initially this child was managed in the hospital by our team. Later on the child went for a few days to the hospice and then she wanted to stay at home among her family and the siblings. So there was a continuum of care for this child. Initially the child was on morphine and then we had to, she needed an opioid rotation to fentanyl, and then towards her end of life she needed morphine subcutaneous injections in addition to the patch. And her end of life care was given at home as she preferred. She had a big wound and the dressing needed to be done. The dressing, many a times she had bleeding. So the team used to go every alternate day and manage the wound. Because of her constant left lateral position, she developed bed sores. We had to provide her an airbed. and teach bed making and skin care to the parents. And our team also assisted that. For dyspnea management, she was on again lower dose of morphine every 8 hours. She had disturbed sleep because of pain, so we had to address that. Her emotional issues, being an adolescent girl, she had fear, she was depressed seeing the wound, and her state of not even being able to turn on the bed. The family and sibling also were in a lot of distress, and there was a lot of anticipatory grief in the parents looking at day to day deteriorating condition of the child and the wound. So we had to sit with the family and establish goals of care, and made a common shared decision that in case a child has more respiratory distress or a bleeding, where she would have had her care given. So the child herself didn't want to come to the hospital. The parents also wanted the care to be given at home. So this child was given end of life care at home, and then also followed up by a bereavement visit. To conclude, I think every child in need should receive a palliative care that is affordable and accessible, and wherever the child wants it. Thank you. And
Okay.
maybe we'll take questions now.
Yes, now the questions could be oral if you want.
Yes.
You can stop
I'll just
sharing.
stop sharing. Yes, yes. Just a minute.
And if you want, because we have plenty of time and we don't need to rush, but do you want that we speak more about the questions that were asked already in the chat? Are you satisfied, or do you
I
want
think we have more sessions on that, Veronique. So maybe
Hmm.
that we can go into detail in those sessions. The questions regarding the collusion and communication. But if anybody wants to have ask anything else, you please welcome.
So Abidjan is asking, chat. May I read it? Does complex psychosocial issues include financial constraints and lead to palliative care referral? I would say it depends a lot on the setting. So that is part of it, financial constraints. And I have to say that we get involved, even though there are, we work hand in hand with pediatric oncology that has also the social workers. So it depends. If you have that support in your PHO department, you have social workers who can help, then there is not so much of need of referring to the palliative care department for that. But if you do not have that, if you are only doctors and nurses in the PHO, whereas you have psychologists and social workers in the palliative care department, then you definitely are going to ask for help from the palliative care. No? That's the way I see it.
Yes, and I think I would say, yeah, even since the palliative care team would be visiting the house, probably the financial status and socioeconomic status would be better perceived by the palliative care team. And we always network. It's not that maybe we would directly help in financial issues, but we always network with other NGOs who can help, or other donors to raise funds. So indirectly, definitely, we can offer a helping hand. Yes.
I think I would invite you to unmute yourself and ask the question orally.
What are the basic requirements to start palliative care along with oncology services? So we do have setting up of palliative care also. I think in the end, topic is there, Veronique. But yeah, so initially, the basic requirement, maybe first it's, see, palliative care is always not done by a single person. It's always a team. So you need a nurse, a doctor who's having basic training in pediatric palliative care. And then if there's luxury, then a social worker also. Otherwise, a nurse and a doctor who's trained in the basics of pediatric palliative care should be able to manage. Because initially you just start helping the oncologist managing pain, and you see that there is so much of more of referrals from the oncologist itself, because the family is happy, the child is happy, the staff are happy that the child is not in distress, the child pain is managed well. So it just starts from managing procedural pain or other kind of pain because of the disease.
Let's take Aarti's question. If you
Hi, ma'am. Thank you. I'm Dr. Aarti. I work in Bangalore. So I had a couple of questions. One, I think someone else has also asked a similar question. So while we counsel them at first for diagnosis, that is itself too overwhelming and a lot of information for them. So sometimes we avoid even giving them the possibility of not being a curative option because cancer equals death in many parts, even in cities, we see the scenario. So to introduce a part like there may not be cure, in which case we will do this. I don't know how exactly it will work out if we start telling them from upfront. I do understand that child life services being a part of the team and being in touch with the parents from the beginning will probably ease it out. But what is your experience? When do you recommend they are first spoken about a possibility of not having cure? We do definitely tell them outcomes, like say suppose even if it's 40%, 50%, say even 20%, we would definitely convey that and then only start treatment. But to put them in a spot where we have to discuss about that 80% chance of not having a cure, I think it's a very difficult conversation in the first few days when they are even trying to accept that their child has cancer. So, how would you deal with that?
yes.
Oh, yeah. You want to take it with?
Yes, so that is definitely that will come probably not at the first conversation because initially, so you are the pediatric oncologist, see the patient, you make the diagnosis. Once you have established the diagnosis, uh, you already have started to have a rapport with the family. Once you have a diagnosis and you have all the risk stratification, then you definitely are going to speak about, you are not going to offer 100% cure to the parents because you have to be honest from the beginning that, okay, maybe out of uh, 10 patients or 100 children or 10 children, 6 are responding well. That means they know that there is a possibility of not responding well. And that honest communication has to be there. Now, when um, you know that the prognosis is going to be poor, meaning we're looking at less than 50%, okay, we're maybe 40, we're looking at 20%, I think the oncologist already knows that is it worthwhile going for a curative intent? So that's the time when, like, we as palliative care team are not called upon for each and every, of course, diagnosis, breaking bad news of diagnosis. We are called when by the oncologist to do joint counseling, to be present when they are going to counsel the parents, that it has a poor prognosis. We are looking at a difficult to treat um, tumor or whatever, and um, and uh, and the parents are not going to be able to listen to everything, are not going to be able to make a decision on the spot. They will need some emotional support behind the scene after that conversation. They will need maybe the psychologist to spend some time to see. Once you tell them something that is very shocking for them, they don't hear anything else. And we might be able to tell the oncologist, okay, let's leave it at that. Give them some time. We'll get back tomorrow or later in the afternoon. No, so but that honesty has to be there at the beginning. As an oncologist, you need to be able to say, okay, we have this curative option, which may be successful in 80%, that may be 20%. Then we have, as Dr. Archana explained, we can try to reduce, to slow down the process, slow down the progression of the disease with oral metronomic chemotherapy, whatever palliative option. Like, all the options can be given. I think that's the way I see it from the beginning. If it is upfront, poor prognosis, difficult to treat. Neuroblastoma stage 4, NMIC amplified in a child more than 18 months old. You have to really explain to the parents that you wish I mean, it's a very difficult decision to make to go for curative intent.
Yeah. Yeah, thank you. Yeah, usually it takes a couple of conversations
Yes.
and probably
It
the
really
second,
doesn't
third.
happen in the first counseling.
Yeah,
Very
yeah, I just wanted to
Yes,
clarify
yes.
that.
So we have one question. Introduction of PPC should be limited at diagnosis only for specific conditions or all for all children. So American Academy of Pediatrics has brought out a position statement saying that PPC should be given to every child irrespective of the trajectory of the disease. The outcome can be full cure, remission, or the outcome can be death. But since the onset of diagnosis throughout the trajectory of the illness, PPC should be offered because initially it is just as a supportive layer when the family comes to the hospital. Maybe the child doesn't have pain on day one, but you need to already tell the family that we are there in case the child has any symptoms regarding the disease or with respect to the chemotherapy or radiation when started. It's always better to have a good rapport and bond with the family because if the child improves and becomes fine, then we are all happy. But if the child deteriorates, they are not suddenly exposed to a new team they have never seen before. Suddenly, it's not a shift from the onco to the palliative care team. So ideally, pediatric palliative care is integrated into pediatric oncology. Like in our setup, we're very fortunate to have pediatric oncologists with us, where every child who's admitted to the hospital is seen by them and seen by us also. And after rounds, we discuss regarding the children in ICU, and it's always a parallel planning and parallel care for the child. This is also comes even from the AAP that it has to be integrated from day one.
Yeah, and I totally agree. It's like there are children who need palliative care referral from the very beginning. Those, as you said, with high risk, with whatever we have spoken about that, but all the children with cancer get to know us because the palliative care department, the palliative care team, takes round in the pediatric oncology department. So, and in all the wards, so they get to know us. They know that if there is pain, if there is distress, whatever, we are going to see that child. The nurses can be the ones giving giving the call. We don't need even the doctors to do it. So early integration actually is ideal, but it is not practical because we have so few pediatric palliative care specialists in the country that you can't do it. You can't do it. Simply, we would be overworked. In a children's hospital like mine, we have most of our work is in non-oncology because there is so much in a tertiary pediatric hospital. The same in Nilofer Hospital. We wouldn't be able to look after any other children if we were to see all the children who are diagnosed with seen by the PHO team. But if we explain to them that it is supportive and palliative, that's the way we call our department, pediatric, palliative and supportive care unit. So we support when there is any kind of distress, whether it is physical, emotional, and so on, at any time of the treatment, especially including when we are looking at a curative option. So, yeah. Yes, Bindu. You are muted. You are muted, Bindu.
Yeah, there's a question on the
Can
scale for pain assessment. Yeah, so we have different scales for different age groups, but I think we have a class on that. So we'll go into detail in the class, Veronique, about the scales. We have NRS, we have Facie scale, we have something called individualized numerical rating scale, we have finger span, different scales for different age groups, and we have a separate class on that. So I think we'll go into detail in the class. So infants, what you ask, we use FLACR. That is, we see the position of the legs, the hands, the facial grimace, that the cry activity that is seen. So we use FLACR for children. We use FLAC for children who are below 6 years, and neurologically impaired children above 6 years. We use FLACR. Otherwise, you can use Feishi scale and finger span, other scales we can use.
We'll take Bindu's question and encourage everyone to speak, to use verbally, to ask your questions verbally, even though we will also answer the questions in the chat. If you have microphone, that would be wonderful. Yes, Bindu.
Yes, ma'am. Yes, ma'am. Thank you for that reply. That the question was asked by me for the introduction of PPC or diagnosis or and when. I got the answer. Thank you so much, ma'am. But the logistics behind that, like if it is a private sector and the integration of the PPC with the parallel planning, financial burden. And another thing is manpower also. Like, can the parallel planning, can we plan every day to the child? So, like, how to adjust for settings of both to overcome this financial burden and the manpower, both?
Manpower to provide palliative care?
No, ma'am. If we have to do a parallel planning, integrated PPC at the diagnosis, suppose I introduce the PPC at the diagnosis for all the children and I integrate them from the day one, definitely it will be the best care possible for the child, because I work in a unit where we have a PPC team and we get to involve them in each children, and I love the way they interact with our kids. That is the best supportive care we can give. But considering the drawbacks of the financial burden, if I get to see the children every day, that is the financial burden, and the manpower, like they have to come and visit the children in spite of their work also. So both the things, how to overcome this?
I think that if the team is introduced in the beginning and then called upon whenever there is a need,
Okay.
maybe that decreases the burden.
Okay.
I started palliative care in a private setup where we would see the patients every day, but charge only once a week.
Okay. Ma'am.
But I don't know. It can be worked out. I know that it is a little bit more difficult, but definitely for the to avoid unnecessary ICU admissions and things like that. Ultimately, even in a private setup, palliative care helps save money. No, because we do not use
At least symptom control. Yes.
Yeah, symptom control, and then you can send patients back home and not unnecessarily use hospital beds when you are not doing investigations and things like that. At the level of even of the management of the hospital, it is actually beneficial to involve palliative care.
Okay. So can we do like at diagnosis and later SOS basis?
Yes.
Okay. Thank you, ma'am. Thank you so much.
Ma'am, there is one more question. Can we prescribe morphine after completion of this course, or even the advanced course is the question?
So after completion of this course, no, because all of us, meaning to be able to prescribe morphine, we need to have an advanced training in palliative care. But at least you will be familiarized with it. You will be able to ask the palliative care physician now there is need for morphine. No, Archana, do you want to?
No, same thing. Yeah, only after the advanced course, then only you'll be licensed to prescribe morphine. So, but definitely you will have I think the morphine phobia will come down after this course, because you'll see how beneficial it is when it is used in the appropriate doses. So, I think there are a few questions, Veronique. Still, what is the sort of conversation or points to cover when discussing the aspect of palliative care in non-oncological conditions? Okay, non-oncologic is a huge separate chapter for palliative care, and most of the time non-oncology conditions we get neurological followed by cardiology and then hematological like thalassemia, sickle and aplastic. Of course, in sickle cell anemia we get more of referrals for pain. So we have the conversation around the pain, and then if there is a possibility of BMT and already that plan is going on, then we always support the family. But we do get children with thalassemia and complications who get admitted into the ICU. Then again, it's a serious illness conversation if we know that the child may not make it. And again, aplastic anemia, we had children who were too sick even to undergo a bone marrow transplant. So again, there it is good end of life care, if possible, memory making, and then bereavement support.
Yeah, in aplastic anemia, we have even much more need for palliative care because most of our kids do poorly. And in thalassemia, I would add our role is very important in ensuring compliance, especially when kids grow up, or there are lots of psychosocial issues. So we may have the palliative care gets the palliative care team gets very essential and in trying to find out why there is poor compliance, for example, to chelation therapy or to the regular visits for transfusions. So home visits are very powerful to understand the psychosocial setup of the family. And then all those thalassemia kids with severe iron overload, with all those complications, become at some point purely palliative, meaning when you have severe cardiac overload, liver, and so on. So what sort of conversation would be there for both ensure that we can provide the optimum care for the child that the hematology, the PHO team is providing, and trying to understand all the issues that the family has. They may have two children with thalassemia. They may have so many issues that may be there. So the sort of the points to cover is like we have usually in our every palliative care setup we have kind of a pro forma and a specific things to cover to assess the all the of course history of illness or the physical clinical examination treatment that is ongoing, then all the emotional issues, all the spiritual issues, and the social issues. So all these will be covered. So it's very important for you as I think as a fruit of this basic course, you are going to learn mostly to learn more communication. This tertiary level of palliative care is recognize, make sure that you recognize pain in all its forms, that you improve your modes of communication with the child and with the families, that you give them a lot of like you assess their understanding and the information that you provide, ensuring that they are able to make decisions. It's a shared decision-making process. All that would be important.
And
How should signature?
sometimes advanced bone tumors with so you're very right, Aarti. We do face many times such children. So there are three things. One thing is usually if they don't respond to morphine, then you have also told about fentanyl. So usually they might require an opioid rotation. So many such children, if they do quite well even on methadone, we are lucky to have both formations of methadone, oral tablets and syrup also. So many of our children do well on methadone. Sometimes we also do need to break the cycle of opioids with by giving a ketamine burst therapy or by using dexmedetomidine for the pains. And second thing, what I would like to say is we should always also think about total pain concept in pediatric palliative care, because sometimes the pain, he might always say it's 8 on 10 or 9 on 10, whatever you do, but there must be some psychological component of pain which we are not addressing. So sometimes when we address that, the pain score just goes to 4 or 3, which is not because of the medication, it is just because we have addressed his psychological issues. Third thing is, even when ketamine infusion and maybe dexmedetomidine also doesn't help, then as a last resort, what we do, we give infusion, as you said, palliative sedation, but in terms, it's initially started only for 6 hours or 8 hours. And then we tell the parents, you see how much he is benefiting from that, or the child. And then if we feel that he's benefiting from that, then that is extended to maybe 8 hours, then 12 hours, then 24 hours. So then the child is comfortable with the infusion. So we usually use an infusion of morphine, midazolam, and haloperidol, and see that the child is comfortable. We face many children like this, and it's really difficult sometimes to handle the pain. But we have enough drugs and formulations available in all preparations. So we give a trial and then do the needful.
Thank you, ma'am.
Tunisha asked, how should signatures be obtained on counseling or consent forms when parents are overwhelmed? My answer would be, do not get signature. Parents are overwhelmed. You have to leave the conversation at that and get back, tell them, okay, see if the psychologist who was present at the can spend some time with them, or even there was no psychologist, you call one and say, can you check on those parents, see what they have understood, how they are feeling, try to help reduce the emotional burden. And whenever they are ready, whenever maybe they have the adequate support, family support to come for the next meeting, the next conversation, then again talk to them. We cannot take signature when they are overwhelmed. Sometimes I see, I mean, it cannot be a consent, at least. It could be a signature saying, I have spoken to you, but it's not fair. It's not ethical, I think.
Yeah, because in our communications, we have a lot of pauses. There are so many days we just need to stop the communication and then again start over another day when they are much more comfortable. So, as Veronique says, I don't think we can take a signature at that time. But we need to understand how much they have understood. That we can again continue in the next session when we meet them. So,
and then parents who are reluctant to get introduced to a palliative care team, they deny at times.
Yeah. You don't need to actually say it's a palliative care team. You can just say there's somebody else who will also help you when the child is in having pain. So you don't need to name at all whether it's a supportive care team, a team, or pediatric palliative care team. There's someone who's also helping you with your child's symptom. So that itself, I think, would work initially. And then because in nowadays anything they'll Google and then they might see, the team which somewhere some myth, a misconception that it's at end of life or something. So you don't really need to name us. You can just say somebody who will help you with your child and make you feel better. That's all.
Yeah, it all depends on the way it is presented.
Yes, ma'am. There is one question, it went missed. Introduction of PPC should be limited at
No, we did that. We did. I think Dr. Bindu or somebody. Yeah, we did that. Yes.
Okay, thank you.
This again, we have another session on this. So
sedation as a side effect. So Anjana, if we end up causing sedation as a side effect, how do we justify stealing their final moments from the parents? I've had parents ask me if increasing pain support means they will not be able to speak again. So the sedation, palliative sedation, is used only in the case of intractable symptoms in order to reduce suffering. And we use the minimum possible level of sedation. And it is something that is reversible. So if at some point they want the child to be conscious because grandfather is coming, before, whatever it is, that is easily done. Meaning this is reversible in many cases. The goal is to reduce suffering. So it's not that we will keep the child sedated till the end as a rule, not at all. So it is very adjustable. No, you reduce the speed of infusion, and then the child wakes up.
The intent here is only symptom control. So again, when the child can get up and eat and again sleep. So as Veronique said, it is set as only per the symptom control. But this might start extending from 6 hours to 8 hours as the disease progresses. And once usually what the parent sees that the child is comfortable, then they say, no, maybe the child needs a little bit more. The whole night the child needs, because child will have a good sleep. So they will only see how it is helping in controlling the symptoms. And whenever they need the child to be awake, all that is done in multiple sessions of counseling. Of course, even when we start the infusion for symptom control, that the child might sleep for some time and not get up like before for feed, maybe getting up after some time. So it all again boils down to communication and listening and communication. So
we have a very, very important question of Tirumala about the possibility of escalating or de-escalating treatment, such as ventilation, when the disease has a grave prognosis, like high-grade glioma. Can we decrease ventilation? Can we stop inotropes? The answer is yes.
yes.
Your question is, although euthanasia is not legal in India, this has nothing to do. We are not talking about euthanasia here. We are talking about good end-of-life care. This is legal in India since 2018 and made much easier since 2023, which is in cases that have what we call terminal illnesses. The patient has the right to deny treatment, or so it is withholding or withdrawing life support when it has become futile, when the burden exceeds the benefit. So in an illness that is like high-grade glioma, we know we do not have any treatment to offer, or you have I don't know, you have so many other conditions where
Metastatic.
you would not even want the child to go to the ICU, and you would make that decision. This child with a refractory disease should not go to ICU and be put on a ventilator and die on a ventilator. So a child is not competent legally to make a decision. The parents are competent to make the decision for the child. So whether it is non-escalation or de-escalation, both are legal and ethically sound in India. So that will be discussed in the end of life care. Do you want to ask more questions regarding that? Before the next question, so Vinila is requesting all of you to put on your cameras, because we will take a screenshot. Please do not leave, because we still have another question. Archana, would you like to take this one? Of Urmila's question.
In the UK, the team is called Patch, and in US, it's called Symptom Control Team rather than calling them Palliative Care Team. And they get introduced to the family during the first time when child is diagnosed, but we get them involved only when needed. But as you rightly said, yeah, correct. I have seen and met them. So bad that the family is meeting ahead of time before everything is getting medically. So yeah, so as you said, it should be integrated so that we are there with the child from day one. And again, as I said, irrespective of the trajectory of the disease, our involvement should be there. If the child does well, well and good. Otherwise, we are there for the child for symptom control and end of life care. I think Vinila is clicking the picture. Is it done, Vinila?
We need to smile. Nandini, Upasana, Vinila. Oh, Vinila. Vinila, also you can show yourself.
Vinila, you can please on your
Show yourself also. Shruti, Malav, you have problems for?
I'm just taking it ready.
We have a few people without camera.
Thank you.
So
we
Vinila
will.
is the one who's doing all the groundwork and has put all the effort for us to start off this session today. And she'll be there with us for all the 9 weeks connected to your pre-test, sending you the resource material and all that. So thank you, Vinila and Nandini. Both of them are helping us to roll out this session today.
So we will look eagerly at your the form that you have filled. I hope everyone has done it. If you haven't, please do that.
There's one more, Veronique. Can we have the link document which states de-escalation therapy, such as, yes, sure. We can share this topic is anyway going to come, medical ethics and end of life care. So we'll definitely share the resources.
Yes, on the WhatsApp group. Great. Any other question?
We miss anything? I don't know. Can we prescribe more? No, that we have done.
So every session will have a pre-test. What about Archana? Is there a post-test?
Yes, there is post-test.
So now you are going to be given the post-test.
Vanilla?
We'll give, and there is one more question, ma'am, meanwhile.
Yes, okay. There will be a detailed section to deal with adolescents, with teenagers, as part of the communication with children. Yeah, and we are going to share. So there will be lots of various faculty which are going to take the different classes. So we are going to share your concerns, your interest also after today's session.
Another thing, I think some topics like palliative sedation and setting up of pediatric palliative care services are a part of the advanced course. So maybe if somebody is interested, no, Veronique, I don't think we have everything in the basic essentials.
Yes.
There are a few topics only exclusive to advanced course. So if anybody is interested, you are more than welcome to contact us. And even anybody wants to come even for a observership or a short clinical posting also, you can always write to one of us and then come if you want to become more confident in hands-on experience with opioids.
Yes.
Yeah, so the
advanced course. Okay. Wonderful, Urmila. Let us finish the basic course because this is the first such course. We are running courses for palliative care residents. We are running courses for pediatricians. And now this is our first
This is the
PHO
first
course.
time we have pediatric oncologists with us. So we are really thrilled and it's a great pleasure to have you all.
And we are sorry we had to limit the number, but we will do other maybe basic courses and then the advanced course. Yes, mainly online, yes. But with the advanced course, we need to have some posting, some observership.
10 days, yeah. Advanced course has 10 days clinical rotation.
So we have various places in the country where we can have that clinical rotation. So we are going to look at the setup where you work, the city where you work. No, we're going to look at your form that you have filled. That will help us also for the upcoming classes. So every week, you will have the pre-test to be taken before the session, and non-pharmacological all approaches will be explained, and all the symptom management, not only for pain, but non-pharmacological measures are being used for management of everything, breathlessness, and all this will be explained. Today is only the introduction. Well, it's very
Can I be cheeky? Sorry. The pre-test and the post-test looks exactly the same. Is that just that you might change your answer? Is that how it is?
Yes.
Because yeah, that's absolute. I just thought by mistake. That's fine. Thank you ever so
Hopefully
much.
what impact the session has, so that we'll know in the post-test. So that's the same.
No, absolutely. Thank you.
If you have learned something. Yes. All right. And we will try to share the material also a little bit more beforehand, no? Vanilla.
Yeah, this time it happened today morning, but next time we'll share it a day or two before.
Yes, ma'am.
Because today there was too many things going on, last minute registrations and all that, opening the link again, closing the link. So the sharing of the material got a little delayed, but I think next time onwards we'll share it before only. Even this sessions are recorded, so later anytime you need also you can we can share it with you. And attendance part, I think Veronique, you already mentioned, no? I think all at least 8 out of 9 classes you have to attend to give the exam and get the certificate.
Yes, I did not mention it, but that is, yes.
It's written, I think, yeah. Thank you so much for all your valuable time and attending this session.
And these sessions will always be on Fridays this time only, or will the timing be changed? It will be on Friday this time only.
Yes, yes.
Always Friday, 7 to 8:30.
But not all, the next Friday, the faculty is not available, so it will go to 23rd.